again. My name is Dr. Nasar Khan, and I'm working as currently working in Queen's University, Canada. I was professor of psychiatry in Pakistan. And most of these presentations I try to do when people ask me a specific topic. So I would love if you people would be able to send me the topics. I would love to cover the topics which are not covered by other psychiatrists in other meetings that you are attending virtually. So there are lots of meetings happening around, and people are teaching and training online, which is a good thing. So you can learn various topics online. The missing component is the patient, and I think that something should be organized in a way that a consent from the patient should be taken, and a case presentation, a live case presentation should be done, which should be discussed the same way as we were doing in Pakistan as a case conference. Or that case conference can definitely be more helpful in you people to learn things rather than just only the theoretical aspects of psychiatry. I always try to give you the practical aspects and the aspects which are covered, which are needed to be covered in the examination. Most of the time, my focus is in examination, because I believe once your examination is passed, then it will be more easier for you to learn. Sorry. So whenever you feel that you want to learn about something, some other topic as well, which makes you intrigued or some confused or something else, you can always ask me. Like I love to present on topics which are generally for social settings, like love, what are the moral issues and how much a psychiatrist is supposed to go for morality, what are the ethical issues and how much a psychiatrist is supposed to know about the ethical dilemmas, the research methodology, how to write a good research paper, and then topics like the relationship issues, topic like sibling rivalry, topics like how to intervene when there are critical situation like a family dispute about property, what is the role of psychiatrist. So all of these issues that are definitely very interesting when you are actually practicing psychiatry. People give lots of different views, but my viewpoint is absolutely clear. We should try to implement psychiatry in the academics and real life practice the same way. It should not be different. Of course, in a real life situation, when we are practicing psychiatry in clinical settings, things do change, but it never means that you should be unethical or you should be having any confrontation with any other academic situation. Second, most of the tricky issues like giving comments related to our colleagues, like giving comments related to that, like recently there was a psychiatrist who died in Multan, and there were lots of debates on it, and everybody was giving their opinion. Psychologists bol rahi hain aur psychiatrists bol rahi hain. I really never felt good about it, because I thought he was a good colleague. He was a good senior person. He was a known name in Pakistani psychiatry. So we should not talk of something or just assuming things unless or until we know all the facts. So most of the people were just giving the comments because they wanted to give the comments and be popular, which is not a good thing. You should only comment when you know. You should not comment on things that you don't know. Always remember, always comment on things that you know. Don't make comments on the things that you don't know. हमारी पाकिस्तानी सोसाइटी में अनफॉर्चुनेटली ये बड़ा एक कॉमन डायलमा है कि हम बहुत बड़े सियासतदान बन जाते हैं, बहुत बड़े रिलीजियस स्कॉलर बन जाते हैं, फतवे देते हैं कि तुम मुसलमान नहीं, तुम काफिर। हम बहुत बड़े स्पोर्ट्समैन बन जाते हैं, जब क्रिकेट का मैच हो रहा होता है तो ऐसे कमेंट्री दी जा रही होती है कि क्या बड़े से बड़े क्रिकेटर को भी क्रिकेट आता होगा। Don't do that. Try to be realistic and give opinions only on the matters that you feel that you are competent enough to give it. That is the key to a successful psychiatrist. और ये जो दवाइयों वाला टॉपिक जो दोबारा से मैं शुरू करवा दिया गलती से या वैसे, सो मैंने कोशिश की कि मैं पिछली प्रेजेंटेशन से डिफरेंट कर दूं. सो दिस टॉपिक again, if you will be able to understand the dynamics of treating a patient having delusional disorder, and you'll be able to pick an appropriate drug right for this patient, it will click and patient will be okay or aapki balle balle. And if you won't be able to do that, then you will be in a chaotic situation. Maybe you will be able to earn money, but you won't be a good psychiatrist. So if you really want to be a good psychiatrist, choosing the right drug for the right patient is a very crucial decision. And if you are able to do that, wonderful. If you're not able to do that, then maybe you won't be able to do the psychiatry the way it should be done. So I will start it now because unfortunately again मुझे जाना है तो मैं शुरू करता हूँ. Whenever we are seeing a patient in outpatient psychiatry, so if any one of you needs to ask me any questions, please do not hesitate to ask me. So whenever we see a patient of psychiatry, of psychosis in outpatient, how can we decide that this patient needs risperidone, or this patient needs clozapine, or this patient needs haloperidol, or this patient needs olanzapine, or this patient needs aripiprazole? So that decision of prescribing the right drug for that specific patient is the key. And it requires your skills and your knowledge both. One, knowledge about the antipsychotic medications, and second, your skills of how you will be prescribing the drug that can help him in getting rid of the symptoms. So starting the point is, whenever I see a patient and if I make a diagnosis of schizophrenia, I will go for the subtype of schizophrenia. If it is a paranoid schizophrenia or catatonic schizophrenia or disorganized or undifferentiated, DSM-5 में इनके नाम फर्क हैं, whatever is the type, I will try to assess the type. Now, if I see a young man who is, say, 20 years of age, having paranoid persecutory delusions, my choice of the drug will be different. If that same man is suffering from catatonic schizophrenia, my choice of the drug will be different. And that is the key, actually. So when all the antipsychotic, whatever the name of the antipsychotics you know are there, when all the antipsychotic are in front of you and you have to prescribe a drug to a patient, like having a positive symptoms, paranoid persecutory delusion, 20 years old young male. Second option, मैं उसको देखूंगा, how is his physique, how is his health, what are the comorbidities, and then I will decide about the antipsychotic. Same goes for every situation. अब वो कौन सी दवाई किस कॉम्बिनेशन में देनी है उसके बारे में थोड़ी सी बात करते हैं. पहले थोड़ा सा बैकग्राउंड बता दूं. Similarly, if I'm seeing a patient in outpatient department and I have diagnosed him as a patient suffering from schizophrenia, but he's having flat affect, he is about 30 plus, having flat affect, and most of these symptoms, the delusions or hallucinations are there, but nothing very concrete, very evident. So probably shaky. Maybe he was getting treatment in the past about for a few months or few years. So in that situation, then choice of my antipsychotic will be different from the first choice. Similarly, if I have a patient who is sitting at one place, having lack of initiative, all the negative symptoms, and there are no delusions or hallucinations, and he is, say, about 25 to 30 years of age, and she's a female, then my choice of antipsychotic will be different. In all these three situations, the choice of antipsychotic varies. So patient having positive symptoms, between 20 and 30, the choice is different. Patient having positive symptoms between 30 years and 40 years, the choice is different. Patient having positive symptoms at 40 and 50 years of age, the choice is different. How to make that choice, that is important. Then similarly, if the patient is having negative symptoms, early 20s, choice is different. Negative symptoms, mid 30s, choice is different. Negative symptoms, mid 40s and 50s, choice is different. That is the clinical skill that you have to develop over the period of time if you really want to be a good psychiatrist. So वो psychiatrist जिनकी practice में ये काम अच्छा होता है, ये स्किल उनको आती है, वो सक्सेसफुल हैं, दे आर गुड क्लिनिशियंस. But if that is missing, then unfortunately you may be able to see huge number of patients, but you won't be getting them well, which is unfortunate. And if they are not getting well, then the choice of your antipsychotic decision making is complicated and you are not a good psychiatrist. Again, a cognitive patient having schizophrenia with cognitive symptoms in 20s, my choice of antipsychotic will be different. In 30s, my choice of antipsychotic will be different. In 40s, my choice of antipsychotic will be different. एक छोटी सी मिसाल देता हूं. Now, this is unfortunately a schizophrenia course. So, schizophrenia onset with prodrome, then there are some remission and relapses, not a full-blown schizophrenia. Then, unfortunately, there is a full-blown schizophrenia where delusion and hallucinations are there. And then person is given antipsychotic medication. He gets better, fine. If he relapses, things are complicated. He gets better after treatment. Then again, he relapses, things are complicated. And ultimately, it's a chronic relapsing residual symptom state where we call it a symptom. Schizophrenia is resistant to the treatment. Similarly, ये एक बड़ी saturated slide है, लेकिन this is the key to prescribe a drug. So if I have a patient and patient is having a patient of schizophrenia diagnosed, say around the age of 20, having a strong family history of psychosis, my choice of antipsychotic will be different. Males, choice of antipsychotic is different. For females, choice of antipsychotic is different, again at various ages. Early onset schizophrenia, I'll be more careful, more aggressive in treating schizophrenia. Earlier the treatment, better is the prognosis. This is the word I have been using it multiple times, so make sure that you understand this. Then, unfortunately, there are various neurotransmitter system involved for various symptomatology. So if the schizophrenia, if I feel, is having more GABAergic interneuronal dysfunction, I will go for a different drug. Well, GABAergic, symptoms related to GABAergic. Then high epinephrine levels, more anxiety, more agitation, then I will go for a different antipsychotic. Then excessive serotonin, like restless, aggressive, violent, homicidal, then a different antipsychotic. High dopaminergic, retardation, slowness, lack of thinking, lack of focus, I will go for a different antipsychotic. Then neuropeptide system, hippocampal interneuron system, all of these things make my decision of choosing an antipsychotic. And this is crucial for you people as well. So when you are sitting in outpatient department, a patient of schizophrenia comes in. It's not that all the patient will be given risperidone 2 milligrams and maybe after a while you will push it up to 3 or 4. No, it's not like that. Although most of the treatment guidelines, NICE guidelines or the American guidelines or algorithms which are relating to treatment strategies of schizophrenia, they don't say directly these things, but they all are actually focusing on these things. So the first line antipsychotic, second line antipsychotic, third line antipsychotic medications given in the treatment strategies or algorithms of these prescribing guidelines are actually variable from time to time. So हर 2 साल बाद एक नई गाइडलाइन आती है, कोई और दवाई टॉप पे आ जाती है, और वो टॉप पे इसलिए आती है कि उसके ऊपर डाटा बढ़ जाता है. देन देर आर मोर एविडेंस अवेलेबल, द सेफ्टी प्रोफाइल कम्स मोर एविडेंट, the people know that it is effective or not, in which kind of the situation is effective. That's absolutely valid. There is no doubt about it. But considering these situations that I'm telling you are important in selecting the drug as well, right? And this is important too. So, a stressful life event in a patient of schizophrenia presenting to you at the age of 30, female, and possibility of pregnancy, I will choose a different drug than a same individual, 30 years old male, having no stressful life events and very much preserved, presenting with schizophrenia. My choice of antipsychotic will be different. Same, if my patient is having substance abuse, he takes cannabis, he takes alcohol, he smokes cigarettes, my choice of antipsychotic will be different than the first person who's just sitting home, not consuming any drugs. He is isolated, secluded, no alcohol, nothing, no socialization. My choice of antipsychotic will be different. So the point I want to make to all of you is that whenever you are choosing an antipsychotic in an outpatient clinic, all of these profile matter. And if you are aware of these facts back in your mind, that this antipsychotic is good in this kind of situation, then choice is good. If you won't be able to understand that, the choice is bad. So you may be a very good psychiatrist by knowing the algorithms presented in NICE guidelines to be writing the script for a patient of schizophrenia in exam situation. But you will be a bad psychiatrist when you will be seeing a patient in outpatient department and choosing an antipsychotic just the way you are choosing it on theoretical basis. Probably it won't work, right? So that is the trick of the trade. And the trick of the trade is that you should be aware and familiar about all of these factors important in writing a drug. For example, ये एक ब्लर सी स्लाइड है. आई होप यू आर एबल टू सी द स्लाइड. बेनजीर, स्लाइड नजर आ रही? नो, ओके. बेनजीर खामोश हो गई.
नहीं आ रही.
ओके, नहीं आ रही, अभी भी नहीं आ रही.
Sir, I cannot see if anybody else can.
Acute agitation.
Sorry, couldn't get it. आ रही या नहीं आ रही?
Sir, एक drug therapy option for acute agitation in pregnant women.
Wow, good. So you can see it. This is fine. So this is what I wanted to show you. This is an example. I am just giving you an example. कि अगर एक फीमेल आपके पास आ जाए जो schizophrenia, the diagnosis is schizophrenia, and you are trying to give her an antipsychotic, or not schizophrenia, say postpartum psychosis, right? Psychotic illness of a patient. No, sorry, not postpartum. A psychotic presentation of a young female who's pregnant. What will you do? Now, the guidelines usually are very clear about it, that these drugs are safe in pregnancy and these drugs are not safe in pregnancy. Like most of the antipsychotic are in FDA category C. But can you imagine that clozapine is in category B? The rest of the antipsychotic, most of them, I'm not clearly saying it, but most of them are in category C. But giving you an example that a clozapine is in category B. So even I have given clozapine to females, and they gave birth to babies who are healthy, and there are research studies available which suggest that people can give birth to healthy babies despite the fact they are on clozapine. So there are data available. So choosing antipsychotic in agitated pregnant women, the first choice would be I cannot give her a benzodiazepine. I should not give her a benzodiazepine. I will try to avoid the benzodiazepine as much as possible. So my choice would be antihistamine, diphenhydramine. Diphenhydramine is a simple old antihistamine. Like I prefer to give promethazine. अनफॉर्चुनेटली पाकिस्तान में प्रोमेथाजीन भी मिलना मुश्किल हो गया, लेकिन माई चॉइस वुड बी प्रोमेथाजीन. मैं प्रोमेथाजीन का इंजेक्शन दे सकता हूँ पेशेंट को, हेलोपेरिडोल का इंजेक्शन दे सकता हूँ जो कंसिडरेबली सेफ हैं. एजिटेशन भी कम हो जाएगी, रेस्टलेसनेस भी कम हो जाएगी, स्लीप भी आ जाएगी और प्रेगनेंसी भी सेफ रहेगी. बट I can give olanzapine, I can give quetiapine, I can give risperidone, I can give lorazepam as well. But I won't go for that. I won't go for that unless or until there are complications. Now, this slide is important just to explain to you how to choose an antipsychotic. I don't know, somehow or the other, the people who are working with me, they always ask this question. What to write in what kind of patient. So this was the reason why I was trying to present again on the drug treatment of schizophrenia. Again, to clarify you people. Normal person, mesolimbic system is normal, mesocortical system is normal, nigrostriatal system is normal, and tuberoinfundibular system is normal. In schizophrenia, with positive symptoms, mesolimbic system is disturbed. In negative symptoms, mesocortical system is disturbed, but nigrostriatal and tuberoinfundibular systems are normal. If I have to give a drug, I will try to make sure that the drug should not affect tuberoinfundibular or nigrostriatal system in people who are having schizophrenia and positive symptoms. Because if I do that, I will make them abnormal as well, which is not the target. So my target is absolutely clear. I have to correct the positive symptoms, leaving the rest of the things normal. So I will choose an antipsychotic which won't hamper or affect the other systems, but affect only mesolimbic system. Similarly, typical antipsychotics, they have effect on positive symptoms, negative symptoms, but they have effect on movement disorders and hyperprolactinemia as well. सारी चीज़ों को इफेक्ट कर जाती हैं. So एक पेशेंट मेरे पास अगर आ रहा है और उसको सिर्फ पॉजिटिव सिम्टम्स हैं, तो मैं उसको क्यों ऐसी दवाई दूं कि उसके पॉजिटिव सिम्टम्स तो ठीक हो जाएं लेकिन उसको नेगेटिव सिम्टम्स भी बन जाएं, उसको नाइग्रोस्ट्राइटल सिस्टम में मूवमेंट डिसऑर्डर भी आ जाए और उसको हाइपरप्रोलैक्टिनीमिया भी हो जाए. I won't do that. Similarly, why should I give a patient an antipsychotic which will address the positive symptoms, but there will be probably hyperprolactinemia or probably cognitive impairment? So I will try to choose an antipsychotic which is safe and address specific symptomatology. This is important. So schizophrenia is a very tricky illness, and it is the bread and butter of psychiatry. And I tell you, honestly speaking, most of the time we earn more money as a psychiatrist by treating people from schizophrenia rather than treating people from anybody else, any other disorder. Same goes for stomach problem. पाकिस्तानी कौम 80% अपने मैदे के बारे में फिक्रमंद और परेशान है. 80% लोग अपने खाने पीने पे फोकस नहीं करते और उनके मैदे खराब रहते हैं और वो गैस्ट्रोएंट्रोलॉजिस्ट की ट्रीटमेंट 10-10 गोलियां खाते रहते हैं. पीपल हु वर्क विद मी दे नो वेरी वेल कि मुझे हमेशा इस बात से एक अनईजीनेस जनरेट होती है. व्हाई दे कैन टेक 10 medicines from a gastroenterologist for 10 years, but they don't want to take a psychotropic one medication to get well and get improved, even for a 6 months time. So that is tricky. And this is because We, you and me, the psychiatrist, are not educating general public the way we should be. हमारा फोकस अगर जनरल पब्लिक की एजुकेशन का होता भी है ना, तो ये होता है कि हमारी प्रैक्टिस बढ़ जाए। ये नहीं होता कि लोगों को एजुकेट दें ताकि उनका आने वाला कल बेहतर हो जाए। अपनी नीयतें ठीक कर लें, चीज़ें ठीक हो जाएंगी। आई ऑलवेज से दिस दैट आप अपनी नीयतें ठीक कर लें, पैसा भी मिल जाएगा, मशहूरी भी मिल जाएगी और आपका मरीज भी ठीक हो जाएगा। वो एक शेर है जो इस वक्त बड़ी जोर से याद आ रहा है। दी शबे वसल मौजन ने अजान पिछली रात, दी शबे वसल मौजन ने अजान पिछली रात, हाय कम वक्त को किस वक्त खुदा याद आया। And this is a common dilemma in psychiatry. Our patients come to psychiatrist, हाय कम वक्त को किस वक्त खुदा याद आया। जब कुछ नहीं बनता तो फिर साइकाइट्रिस्ट याद आता, वरना उससे पहले न्यूरोलॉजिस्ट, गैस्ट्रोएंट्रोलॉजिस्ट, पैथोलॉजिस्ट, blah 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 blah, everybody is treating the psychiatrist, including the psychotic. Now this is an old slide, but just to briefly highlight you about this slide, that I'm sorry, there was some word. Okay, this presentation was done earlier as well on psychosis, so I will just spend 5 more minutes and then we will move on to a specific topic next time, which Dr. Manur was saying in the beginning, that we have to try to cover general psychopharmacology rather than specific. So every psychopharmacology related to all the drugs. So I will try to cover up as much as possible. But still, I will say it again. If you want to know, or you want me to present on some specific topic, like the examples I was giving to you, marital disharmony, anger, aggression, social issues like how we should counsel a person who is divorced by a manic patient, how to address the issues, ethical issues in property disputes in psychiatric patient situation, blah blah. So इस किस्म के अगर कोई issues आपके ज़हन में हो तो ज़रूर मुझे बताएं, मैं present करूँगा, and I definitely would love to give you the scientific background for all those issues as well. So in 1840s, psychosis was identified. Then the first treatment for psychosis, will you believe it, that now we believe that the cannabis is a substance which can precipitate and worsen the psychosis in certain forms. Initially, the cannabis was used as a treatment for psychosis for a very long time. So लोगों को भांग पिला के साइकोसिस को ट्रीट करने की कोशिश की जाती थी, और बाद में पता चला जी इससे तो साइकोसिस वर्स हो जाता है। सब्सटेंस इंड्यूस साइकोसिस की टर्मिनोलॉजी लेटर ऑन डेवलप हुई. सो दिस इज अनफॉर्चुनेटली साइंस. when we go historically on the backgrounds, we understand that how things evolved. And then in 50s, 1950s, 52 में क्लोरप्रोमाजीन पहली दफा आई. सो वो जो जॉन नैश की मूवी बनी ब्यूटीफुल माइंड, जिसमें उसको 400 मिलीग्राम ऑफ क्लोरप्रोमाजीन दी गई, जिससे उसने नोबेल प्राइज इन मैथमेटिक्स अचीव किया, was a breakthrough in the treatment of psychosis. And then of course the medications kept on coming. So 1952 chlorpromazine was identified, then 1954 chlorpromazine was approved by FDA. 1959, now clozapine first was prescribed in 1959, and unfortunately it was prescribed for quite a significant period of time, and then people started dying because of clozapine. उससे एक ग्रेनुलोसाइटोसिस हुआ, डेथ्स हुई, क्लोजापिन से लोगों का एतबार उठ गया, लोगों ने लिखनी बंद कर दी. अभी भी लोग डरते हैं क्लोजापिन देते हुए पाकिस्तान में. इट्स अ वंडरफुल ड्रग. It works very well in people who are not responding to other drugs. So we should not be afraid of it just because it causes agranulocytosis. So it was relaunched in 1990s probably or 2000s again, and then it was given. And then risperidone, olanzapine, and other antipsychotics came and then was prescribed. So whole bunch of list of drugs, antipsychotic drugs, phenothiazines, aliphatic, chlorpromazine. I still prescribe chlorpromazine to my patients here. It's not available in Pakistan, but it's a wonderful drug. Levomepromazine. I still prescribe Nauzinan, methoprazine here to my patients who are not responding to the new antipsychotic medication. But unfortunately, Nauzinan or methoprazine or the phenothiazines are not available in Pakistan anymore, which is bad because those drugs still work wonderfully well in certain kind of the situations that I have mentioned to you earlier. Why to choose and how to choose the medication. Then piperidines, pericyanine, pipotiazine, thioridazine. Thioridazine was prescribed for ages and then it was discontinued because of one of the side effects, retinitis pigmentosa. I don't think so. It was just a side effect. I think it was more of the company was in loss, so it just again withdrew from the market and just stopped producing thyroidazine because it was no more profitable drug commercially. And this is unfortunately the problem. So the pharmaceutical companies, most of the time, they stop manufacturing the drug because they are no more profitable, which is a bad thing for the patient and for psychiatrists too. Then piperazines, flufenazine, perfenazine, chlorpromazine, trifluparazine. These were all drugs which were wonderfully prescribed for almost 50 years in psychiatry to treat psychosis, and then they suddenly disappeared from Pakistani market. We can find some of them, but not all of them, but they still work well. Flupentixol and zukupentixol injectables and oral tablets. Oral tablets are no more available, but the injectables are available and they work well. Then benperidol, haloperidol, droperidol, butyrophenones, diphenyl butylo, piperidines, pimozide. Pimozide is again not available in Pakistan. Then atypical antipsychotic, that is the era that you people are prescribing. So all of you are prescribing aripiprazole, olanzapine, quetiapine, risperidone. You don't have sertindole, zotipin. You have lurasidone, ziprasidone, and few other new antipsychotic like brexpiprazole and Safril, which is Safril. उसका नाम मुझे ज़हन में नहीं आ रहा, but आएगा तो बता दूंगा. All of these antipsychotic drugs, they work well on psychosis. Again, if the choice of the drug is appropriate to the patient's profile, which I mentioned to you earlier. If the choice is good, patient will be okay. If the choice is bad, patient will not be okay. Right? Okay. I will stop here, unfortunately, because I have to go and attend another meeting shortly. So, but please do send me topics if you feel, if you want to learn anything specific in psychiatry. Otherwise, I will try to continue with this topic and the general psychopharmacology of other medications and see how much I would be able to cover. Now, these topics are not the topics which can be covered in just one single sitting. They are huge topics. They need, well, covering it just swiftly like this would be easy, but it won't be any good to you. So I want you to understand all the drugs before you will be able to prescribe them. Any questions? No question? That's okay.
Sir,
Amatullah wants to ask a question.
Sure, go ahead.
Amatullah